Hello and welcome to Fertility Fact or Fiction, our show every week where we talk about all things related to infertility and try and dispel the myths and bring you the truth about what you need to know to have a successful outcome. We're super pleased to be with you guys tonight. We have a great topic that was driven by your comments last time and a whole lot of likes and interest. So we're going to review mosaicism, and it's less a review of a paper, although I do have one to review with you. But kind of a general review of the topic. So hopefully you guys all have your tea, coffee, and some time to spend with us tonight. And as always, we will be answering your questions live. So if you have any questions, don't hesitate to ask. You can start asking now, and we will go back and look at them later on. But we always spend the first few minutes just talking about a specific topic. So we're going to talk about mosaic embryos tonight. And this usually requires some genetic input. I did take some genetics courses. I am by no means a geneticist, but I think I have enough knowledge to pass some along. And hopefully we'll make sense out of it for you all. And I think it's actually some really encouraging data overall. So thank you to those of you who jumped on our poll today on Instagram and talked about what your thoughts were in terms of, does it have the same or a lower chance of implantation if you have a mosaic embryo? So we're going to go over all of that today and chit chat about that. Park's working on pulling up some of our charts and data, and I'm going to kind of establish everything for you from the get-go and explain it all. So the reason that this became an important topic was because there was a big shift in IVF going back probably 10, 12 years ago, where they first discovered the ability to determine if an embryo was genetically normal or not. So way back in the beginning, they were actually biopsying day 8 embryos, removing one of the cells, analyzing it, and then determining if the embryo was normal or not. Unfortunately, that turned out to be very harmful for embryos. And so very quickly, they realized that was not the right way to do it, and that they should jump into doing the biopsies from what's called the trophectoderm instead of the inner cell mass on a blastocyst. So I'm going to explain that in plain English. When your embryo makes it to the blastocyst stage, which is typically day 5, day 6, day 7, at that stage, there are 2 different groups of cells. So there's going to be there's going to be an inner cell mass, which is the portion that's becoming the baby. And there's going to be trophectoderm, which is the portion that's becoming the placenta. So when we do endometrial biopsies, or not endometrial, embryo biopsies, what we do is we laser hatch the embryo by drilling a little hole with a laser in the shell of the embryo, right where the trophectoderm, which is the placental portion, is. And as the inner cell mass expands, because it's a growing population of cells, it pops through that hole. And so a little bit of tissue will come out and around that little drilled hole you've made with the laser. And it's trophectoderm that's coming through. And then you can take the laser and trim off more pieces. And you're now sending that off for assessment. So what they realized was that they could determine that there were genetic abnormalities or not based on what the placental tissue showed. After they started doing this for quite some time, people started realizing that some of the cells in that trophectoderm had normal genetic makeup, meaning 46 paired chromosomes, and some of them had abnormal genetic makeup. So you could have pieces missing from chromosomes, you could have whole chromosomes missing, or added pieces or added whole chromosomes. So that was then called a mosaic, because like a mosaic tile, you had some that were one shape and some that were another, and all of these pieces kind of fitting together. But they didn't know what that meant in terms of the inner cell mass, because no one wants to touch the inner cell mass and damage embryos, because that's where the baby is. So we assumed that all of those embryos were genetically not normal. So as time went on, people actually started getting a bit more worried, because not everybody will make normal embryos. And so the question was, what do we do with these half normal, half abnormal embryos? Is there any chance that they're going to implant? And the answer to that was no one knew. So they started analyzing this more carefully, and then they started differentiating it into what's called high-level mosaicism and low-level mosaicism, and there's no agreement on what that is. But at the end of the day, what ended up happening was that the scientists and the geneticists and the labs all said, we need to decide whether or not these are worth transferring. So after extensive counseling of patients, people did start transferring mosaic embryos into women, and they ended up getting live births. In fact, there's only a couple of reported cases where a mosaic embryo was transferred, resulted in a pregnancy, and the baby or the infant actually had a genetic problem. Once you're pregnant with the mosaic embryo, they were finding that they were normal. So then people started scratching their heads and saying, wait a minute, what's going on? So how do we analyze this? So essentially what they've done now is spread this into two segments, these high-level mosaics, where depending on which manuscript you read, somewhere north of 40% of the cells are abnormal. So you've got that normal population and the abnormal population of cells mixed in together. If more than 40% of the sample is abnormal, they call that a high level. Some arguments say 50%, some even say more than 20%. And then if it's less than that number, then you have a low-level mosaic. So the question then that followed was, well, what are the outcomes from these low-level mosaics? So several studies have been done. And if you look at the American Society of Reproductive Medicine conference that's coming up, the abstract for mosaicism has like 50 or 60 papers in there. It's crazy. There's tons and tons of studies coming out where people have specifically been looking at this mosaic question. And probably one of the most important studies came out in fertility and sterility back in July of last year, where they examined a huge number of these mosaic embryos, over 1,000 of them, to see what the chance would be for implantation. So I want to kind of go over that study, and I think Tarek's got some stuff there for you to look at. So essentially what they did was, this was a multi-center study. It included clinics from California, New York, a couple of places in New York, Taiwan, Milan, Italy, Rome, Italy, another one in Rome, and then one in New Jersey. So they had huge, huge numbers of embryos available to them. Specifically, I think there were over 5,000 normal or euploid embryos that were being transferred. And then they had 1,000 of these mosaic embryos, and 860 were used in single embryo transfers. 88 of them were used in double embryo transfers with another mosaic embryo. 50 were used where they put in one mosaic and one normal. And then there were a few more where there was no testing and they just kind of blended them all together. So essentially they went through the data, and if you go to, I think, the first figure 1, have you got that? So if you can look at the bottom part of it, because the top parts are not that critical, the bottom part will show you implantation, ongoing live birth, and spontaneous abortion. So hopefully you can see it. The first bar says euploid embryo. So they had great implantation rate. It was 57.2%. So very, very robust numbers, a good solid implantation rate. If you have a mosaic embryo, looking at all the mosaic embryos, these would be ones that had just segments of chromosomes added or missing, or an entire chromosome added or missing. You had 46.5%. Now that is lower, and it was statistically significantly lower than the 57.2, but still pretty robust results. I mean, you're still getting almost half of those embryos to actually implant, which is hugely important. And then if you had embryos in that third bar where the whole chromosome was added or deleted, that was 41.8%. So again, remember, these are all embryos where some of them are normal and some of the cells are not, and it's mixed in together. So then they went and looked at the ongoing pregnancy rate. And in this study, you're seeing 52.3% that had an ongoing pregnancy if the embryo was normal. versus 37% for all mosaic embryos, and then 31% if a whole chromosome is added or missing. So obviously the mosaics, where it's not just pieces of chromosomes missing, but the whole chromosome missing, are a little bit more difficult to achieve implantation success with. So then they looked at spontaneous abortion, and if you have a euploid embryo, your miscarriage rate is still substantial. It's 8.6%, and that's an important number for everybody to know, because everybody thinks if they do PGTA, they're reducing their chances of having a miscarriage. But the truth is, you're still going to get miscarriages even with euploid embryos. We don't know why. There are a variety of different possibilities. It does go up quite a bit with these mosaic embryos. You're now looking at over double, 20.4%. And then if it was the whole chromosome, it's 25%. So a further increase. And again, all of those are statistically significantly different from the euploid embryos. When you went and looked at it in terms of the different mosaics, looking at positive outcomes and so on, and the different severities of the mosaicism, again, they have lots and lots of robust numbers. But the one that's really important to look at is that they're not seeing a huge difference in implantation and ongoing pregnancy rate with the mosaics that had less than 50% versus greater than 50% if you're already pregnant. So once you're pregnant, that difference of less or more than 50 doesn't really make a huge difference. You're still getting reasonably robust outcomes with that. So what they said from all of this is essentially that if you have a mosaic embryo, you have a very reasonable chance, if it's a low-level mosaic, that you will get implantation. And once that implantation has occurred, your chance of having a live birth is actually very reasonable. They've got an even better study, which I tried desperately to find for you all today, to demonstrate, where they actually blinded the physicians to whether or not the embryo was genetically normal or not. And then they told them to go ahead and do the transfers. In that study, there was actually no statistically significant difference between the euploid embryos and the mosaic embryos that were low level, meaning some of the reason that we're seeing these differences in numbers in these other studies is because of bias, because they're cherry picking embryos for patients. Whereas if you don't actually know what the embryo is and if it's normal or not, you can actually get the exact same results with the mosaics and the euploid embryos. Now, that was only one study, and the majority of other studies do suggest that when you're putting in a euploid embryo, which is genetically normal, versus the mosaic, you have a better chance with the euploid embryo. But that one study is actually quite well done, and as soon as I can find it, I will put it up on our site for you to take a look at. And it does demonstrate that the mosaics seem to have the same potential. And it was about 50%, I think it was 46% in that study that I read, demonstrating a very reasonable chance that that low-level mosaic can implant. So the question then everybody has is, well, what's happening in that embryo? So the answer is, in the trophectoderm, the part that becomes the placenta, you can actually have different populations of cells and still have a normal embryo. More importantly, there are studies out there where they went back and biopsied the inner cell mass and even re-biopsied the trophectoderm and showed huge discrepancies. So in particular, one study showed only 16% of the embryos that they called mosaic were still mosaic when they repeated the biopsy. Some had differences in what they found, so it looked like the first sample was wrong. Some showed that it was completely normal the second time around, and other ones demonstrated that there were abnormalities that they hadn't picked up before, which were showing that it was quite significant. But the important thing is the agreement from the first biopsy to the second biopsy was only in the 10 to 15% range. More importantly, when they've gone back and actually biopsied the inner cells where the baby is, which thankfully they are not doing a lot of because there's all sorts of moral questions with that part, the reality is that those inner cell mass cells are all coming out normal in these low-level mosaics, or many of them are coming out normal. what they're realizing about these embryos is that the embryos actually have the ability to kick out the abnormal cells from their cell population. And therefore, even if you start off with some cells that are abnormal, the embryo actually knows how to correct itself in some cases and can get rid of those abnormal cell lines from the portion that's becoming the baby, so that even if the placental tissue is abnormal, the inner portion can still be normal, and therefore you can result in a normal baby. So the statement, and they've got other studies on this as well, that you should just discard all the mosaic embryos is no longer true. In fact, there are people now arguing that if you have a low-level mosaic, it should actually be classified as a euploid embryo. It should be classified as a normal embryo because it's going to give you roughly the same implantation potential, maybe a slightly higher miscarriage rate. But otherwise, you still have a very good chance of ending up with a genetically normal baby at the end of that transfer. So the other 2 points that came up when I looked at this, which were very, very interesting for me, are that they are saying that once you pass that stage where it implants and it goes on, you no longer really have to worry if you make it past the miscarriage risk about the embryo. You're likely going to have a genetically normal child. Most people would still advocate for doing an amnio, so you can actually get fetal cells rather than placental ones. But it does look like the result is going to be that you have a very realistic chance of ending up with a normal child. The other thing that's interesting is that, or 2 parts actually. One is that normally with age increasing, we see an increasing number of genetically abnormal embryos, but mosaicism actually decreases with age. So women that are older are going to have to deal with this less than women that are younger, because their embryos tend to be just kind of outright abnormal instead of mosaic abnormal. So your age will play a role. It's actually protective from mosaicism, but at the same time, it's got a much higher risk of having abnormals. The other study that is coming out, and I think it's just in abstract form right now, and it's being presented at ASRM, is that if you have a higher percentage of mosaic embryos than normal, then even if you have euploid embryos, the euploid embryos have a lower chance of staying or sticking and staying. In other words, if you have, let's say, 3 or 4 mosaic embryos, a couple of aneuploid embryos, and 1 or 2 euploid embryos, those 1 or 2 euploid embryos are going to have a lower chance at implanting and remaining compared to the patient that has 1 or 2 euploid embryos and then has only a couple of mosaic embryos, like maybe 1, and then has whatever number of aneuploids. So the lower the number of mosaic embryos that you have, the better your chances are, even with your genetically normal embryos. And that has not been shown yet. So that is a very, very interesting study that's coming out. So this is a very rapidly evolving area. Literally in 2019, the Pre-Implantation Genetic Diagnosis Group division of ASRM issued a statement, and then literally a year later, they basically retracted it and said, well, now we have a different statement, because they were realizing that these mosaic embryos actually do have implantation and ongoing pregnancy and live birth potential, resulting in normal pregnancy outcomes. So is it a fact or a fiction that your mosaic embryos have a lower chance of implantation? Actually, we don't know yet, but it actually looks like it's a fiction. Overall, it would appear that you're going to get a very reasonable chance of success. And if you are successful and it attaches and it continues to go, your chance of having a normal baby is quite high. Now, should you check to make sure the baby is okay? That's certainly something that is available. You can do NIPT, you can do amniocentesis, there's CVS. But realistically, once you've got an ongoing pregnancy, the chances of a normal pregnancy are quite high. And it's very, very few reports of genetically abnormal children being born from mosaic implanted embryos. So I think this is overwhelming for a lot of people, because many of you have embryos. And they do have studies now looking at, should you do another study, a cycle, sorry, of IVF if you only have mosaic embryos to create more normal embryos, or should you go ahead and use the mosaic embryos? And I would actually argue that it is entirely reasonable to use your mosaic embryos before having to go ahead and do another cycle, unless you're trying to do embryo banking, which is a different story. But if you've done a cycle and you have 1 or 2 low-level mosaics, you actually have very good chances with those, and they should be tried before you spend all that money again to go for another cycle. You do need genetic counseling. It's a long discussion. You got to understand your risks and your benefits, but it is well worth considering that those embryos have a very solid chance. So I hope that you've enjoyed that part of the show. We will definitely have that up on our YouTube channel soon, and I might come up with a whole mosaic embryo kind of video like we have for embryo math and some of our other topics. Just before we get to your questions, I have spent most of today doing my obstetrical day trying to convince people to get vaccinated. So just to go over the vaccine again, because somebody always asks this, and many of you are still hesitant. There is no reason to be hesitant. The vaccine cannot negatively impact your pregnancy or your fertility or cause cancer or anything else like that. All the stuff people are reading about and all the people that have now suddenly gotten their Facebook medical degree have no clue what they are talking about. There is no reported adverse outcomes from taking the vaccine in any peer-reviewed journal. Nothing. Literally, it doesn't exist. So please, if you can get vaccinated and you are trying to get pregnant or you are pregnant, please go get vaccinated, especially if you're already pregnant. It is a 1,000% increase in your risk of ICU admission and a 2,230% increase in your risk of death if you contract COVID while you are pregnant. So I beg you, stop becoming Facebook doctors. Stop listening to people that think that they are Facebook doctors. Please go get vaccinated. It is imperative for your well-being and the well-being of your baby. And it cannot affect your fertility or your pregnancy. It is biologically not possible to do so. So we're ready for questions, and I need my tea.
It's just the Instagram people accidentally swiped left, so the comments
are gone.
So they need to, Instagram needs to re-ask.
So if you were on Instagram, your questions disappeared because we had a technical glitch. So please re-ask your questions if you're asking on Instagram, and we will attend to them right away. And sorry. By the way, for all the people watching on Instagram, we've had quite a few people who have reached out to us through the show, and we are now helping from all over the world, Australia in particular, a lot of people from Ireland. Hopefully our friend from Sweden is asleep this time because her baby was sick last week. But listen, if you guys need help, that's what we're here for. We're here to help you. So reach out and ask us your questions. And we've helped tons of people now. Every day, at least 1 or 2 people message me and say the info they got from our show has helped them conceive when they couldn't before. So for sure, let us know, because we always want to help you. Yeah.
Related to the topic today, is a mosaic embryo better than a day 7 euploid for transfer?
Yeah, so actually, there are studies that have looked at that. There was one study in particular I kind of raced through today, but it actually showed that a day 5 mosaic low-level embryo has a higher percentage chance than a day 7 does. Day 7s are down to about 15%. As I showed you, you're getting like 30s and 40s for these mosaic embryos. So a mosaic day 5 or day 6 has a higher percent chance than a day 7 embryo does. And that's a fantastic question. So lots of thumbs up and hearts and all that fun stuff on whatever platform you're on.
How long's waiting for surgery in Windsor right now?
Depends on how urgent the need is, but a couple of months usually, and we can get you in.
How long do you have to wait after an egg retrieval, 10 follicles, before you can have a hysteroscopy laparoscopy?
Oh, like the next month if you have a place that can offer it to you. Yeah, you don't need to wait.
How many patients do you find donate embryos to science versus adoption or discarding them?
Oh, that's a great question. You know, it's such a personal choice. Because of my religious beliefs, I do try and encourage people to donate rather than to discard, because I hate discarding embryos. But it's very personal. I mean, some people just don't feel comfortable giving up what is essentially their child. And I totally respect that. So it depends on where the embryos came from and who they came from. For example, in our same-sex community, you'll find that they will very frequently donate the embryos, whereas in heterosexual community, they will, but it's less common. So it's probably somewhere around 15-20% of our patients that will donate. In the heterosexual community. In the same-sex community, it's usually almost everybody. So it depends on where the embryos are coming from.
Do embryos have the ability to self-correct once implanted?
Yeah, they do. So that's what I was saying earlier. A mosaic embryo can eject abnormal cells, and they're showing that by day 12, an embryo will actually either become aneuploid or euploid. So you can implant it on day 5 or 6 with a mosaic, and by day 12, it itself either corrects or becomes abnormal. And if it's abnormal, most of those are going to miscarry. The vast majority of those are going to miscarry, which means, yes, unfortunately, you will suffer a miscarriage, but it's highly unlikely you'll end up with a pregnancy that is carrying an abnormal child.
Hi, Dr. V. Do you believe in lining being too thick to transfer? My current clinic does not. They also do not show concern if lining isn't trilaminar at transfer. My lining has been over 10 millimeters at baseline, and I'm concerned that there is an issue, especially since I've had 2 failed FETs.
Yeah, so your lining can be too thick. In fact, my embryologist is very strict about lining thickness. She doesn't want it more than 10, 11 maximum. And there are studies that show that if you have a very thick lining, that your chances are reduced. So if you're 10 at baseline, that's a very, very thick lining. That's one where I would probably want you thinned out for a long time ahead of time with, progesterone or something, and then just take some letrozole to keep your estrogen levels even lower as you get your lining to thicken. As far as, failure with that, yes. I mean, if your lining is super thick, your failure rate will be higher. As far as trilaminar, it has to be trilaminar before you start your progesterone. Once you've started your progesterone, it loses the trilaminar appearance. But before you start your progesterone, you should never be starting if it's not trilaminar. Make sure they've done a saline infusion sonohystogram on you to make sure that the lining is normal. You don't want to find out later on there is a polyp or a fibroid, because those can reduce your chances by 50%, 50.
That was a good one. I was reading for them. Okay, I'll go to Instagram. Yes, they're asking.
Okay.
They know. Both tubes blocked 4 weeks after DNC for retained products. 6 weeks after pregnancy lost at 16 weeks gestation.
Oh, I'm so sorry.
To repeat HSG in 2 cycles. RE says only option is IVF. What are your thoughts?
Well, unless they damaged your uterus at the time of your DNE or DNC for your loss, it would be incredibly unlikely that your tubes that just helped you get pregnant are blocked. Now, if you did an HSG and it was painful, your tubes will go into spasm. So HSGs are very, very delicate. You got to go very, very slowly. You cannot cause pain. Ideally, you try and warm the oil. And you just go super, super slow. If you are going quickly, it will hurt. And the minute it hurts, your tubes clamp down. And then it's going to think that you're blocked. But how could you be blocked if you were just open? So I would strongly disagree with that statement and want that checked inside out and backwards before I would jump into doing IVF. You really need to have that carefully evaluated before you spend all that money on IVF, because it's probably not necessary if you were just pregnant naturally. At least from the blocked tube standpoint. I don't know what else is going on, but from that standpoint, you really shouldn't have to do anything.
So this is a question that was posted on the HCG and age video.
Oh, yeah, sure. Yeah.
It seems that you find it important to give quantitative information to your patients. Are you able to provide a chance of ICSI treatment after evaluating their patient's medical history?
A chance of ICSI treatment?
Yeah.
I'm not sure what you're asking, but yeah, I mean, if you watch our embryo math video, you can literally calculate what your chances are. So yeah, there are ways to calculate what someone's chances of success are going to be. Is it going to be exact? No, I'm not going to hone it down to 10.1%, but I can give you a very realistic range of expectation for what to expect for people. So you know, it's pretty easy to tell people what their opportunity is going to be like if I have all of the needed information: sperm quality, DNA fragmentation tests, health habits, and so on, FSH, AMH, your body mass index, your age, prior cycles, that kind of thing, antral follicle count. I can give you a reasonable estimate of what your chances are going to be. I'm by no means, you know, able to look into my crystal ball and tell you exactly what the numbers are, but we can give you a very realistic range. And I don't inflate the numbers. I give you exactly what comes out of the science part of it. But watch our embryo math video. We're up to 45,000 views now. Yeah, I want to hit 50. So anyways, yeah, check out embryo math. It basically spells it out for you. You can calculate it on your own from the information that's there.
Hey, Dr. V, do you recommend stopping blood thinners if SCH develops? I'm 6 weeks, have a...
Yes, don't worry.
Okay.
Yes, if you've got an SCH, stop your blood thinners for sure, because it's only going to expand in the presence of a blood thinner. So we stop, we monitor the blood thinner, we make sure it's evening out, and then if it's evened out, we go on. So yes, definitely stop. Definitely stop. Yep.
Lost IUI pregnancy at 23 weeks due to undiagnosed appendicitis. Whole abdomen was black on CT, treated with antibiotics and surgery. Both tubes ruined and removed. Told uterus was normal.
Wow, I'm so sorry.
FET chances?
Excellent. I mean, as long as they got rid of the infection, and that's a case where I'd probably want to do the fertilizist to make sure that the inside of your uterus was not damaged, then you should be perfectly fine. There's no reason why an FET wouldn't work. And I'm so sorry you have to go through that. That's terrible.
What is the significance of an embryo that has not expanded enough after hatching to safely take a biopsy? Is there still a chance of pregnancy with that embryo?
Oh yeah, absolutely. I mean, ideally your embryos expand. But if it doesn't expand, you still have a good chance. In fact, there was an article I read day before yesterday that showed that the embryos of the same quality and the same day have no difference in outcome between expanded versus non-expanded from a frozen embryo transfer. So if it doesn't expand, it may not be as robust an embryo because that's time dependent. So if you've got a day 6 unexpanded embryo, it's clearly not as good as an expanded day 5. But nevertheless, it still has very good implantation potential, yes.
I've had a history of atypical hyperplasia and just had failed IVF round. I'm now 35, my hormones are normal and balanced, natural cycle. Is there hope? Hyperplasia treated with IUD and cleared.
Is there hope? Yeah, for sure. I would want to know what had been done. So I need more information than what you're giving me, but we have loads of patients that have endometrial hyperplasia and they go on to have completely happy, healthy, normal pregnancies. So that's not a problem usually. Yeah, you can definitely achieve success and you can achieve very reasonable success. It would depend on why you had endometrial hyperplasia. So if you're PCO, if your body mass index is very high, all those things can lead to complications where your IVF may fail. So that's a separate issue altogether. But if you had kind of endometrial hyperplasia and you're thin, that's a different story altogether. You should be able to solve that, resolve that, and have a successful outcome without very much difficulty at all. And for the patients that are struggling with their weight, there's options there too, but obviously we have to deal with all of the health issues to maximize your chances of success.
During my current medicated FET cycle on estrogen, they are seeing fluid and growth in the uterus. Previous medicated cycle was canceled because of this. Do you have any thoughts on next steps?
Yeah, so there's 2 elements to that. Well, 3, I guess. So number 1, you need to make sure you don't have hydrosalpinx so that there's fluid in your fallopian tubes, because if there is, it can leak into the uterus and that fluid will absolutely stop you from getting pregnant. It's a 50% reduction in success with IVF. So make sure you don't have hydrosalpinges, swollen, water-filled fallopian tubes. Number two, make sure it's not from your C-section scar. If you've had a previous C-section, you get this little steeple defect in the lining of the uterus. It's called an isthmocele. And that isthmocele can actually cause problems where it collects some old blood. It's a nidus for infection. And then you'll get fluid buildup in the uterus. Excuse me. The third thing is that you might have infection in your uterus. So if you do have infection in your uterus, you need to fix that because otherwise there is no way to get it to work. So for sure, check all of those things out. If you're still producing fluid, there are studies that have looked at that. The success rates in putting in those embryos is terrible. It's like 0. So don't do that. You might need to consider surrogacy.
For someone that did IVF due to a tubal after 3 natural pregnancies, 1 FET, which was a live birth, retrieved while 23 years old, what is the chance of success with another 4 AA transfer?
If you made your embryos at 23, probably somewhere around 80%, 90% in the right hands. With the right protocol, if you're healthy and everything else is normal, you'd have an extremely high chance of success. Those are the ones where we don't even worry about it.
Is it true that the risk of Accreta is much higher with IVF after multiple C-sections? What is the risk? Are there associated risk factors?
So your biggest risk factor is multiple C-sections. After 3, your risk of a placental implantation abnormality is very high. IVF makes it even higher. So yes, your risk is very substantial if you've had 3 C-sections already. It varies from study to study, but up to 25% of patients can have placental implantation abnormalities, and that's not a minor thing. It can cause fetal problems, and it will definitely cause maternal problems, because if you get a placenta that's increta, accreta, percreta, you're going to need your uterus out when we deliver the baby. So that's not like without its significant risk of harm.
Blocked tubes 4 weeks after DNC. For retained products 6 weeks after pregnancy loss at 16 weeks.
That's the one that asked us earlier.
What test do you recommend for 35-year-olds with unexplained secondary infertility? Good AFC and AMH, normal FSH, no PCOS, husband has good sperm, no blocked tubes. We failed 3 IUIs with gall alive.
So I would probably add in sperm DNA fragmentation testing because you need that to make sure it's not coming from that. I would want to know more about your history: no smoking, no drinking, no drug use, your body mass index, surgery to rule out endometriosis, infection checks, ureaplasma, mycoplasma, fertility testing for the inside of your uterus. There's a whole slew of tests that can be done, but those would be the major ones that we would look at. Thyroid testing, making sure you don't have thyroid abnormalities, thyroid antibodies. All of these can be significant.
If you have poor egg quality but good sperm quality, very low DNA frag, normal labs in a couple, is traditional IVF more effective than ICSI on poor egg quality?
No. One word answer. Yeah, so in the right lab, ICSI is always going to give you a much higher chance of fertilization. There's a lot of argument back and forth about this because all of the studies that compare conventional IVF to ICSI have an average of like a 70% ICSI success rate versus like 50% with the conventional IVF. But we're getting like over 90% of our eggs to fertilize. So when you're getting that high a success rate, those studies just don't apply. So if you have poor egg quality, it's even more important, in my opinion, to do the ICSI because you want to try and get the highest number of embryos possible. And by getting the highest number of embryos possible, you're actually increasing the chances that you'll find one that is genetically normal. It's a numbers game at that point.
What are the chances of a low-level 40% segmental mosaic, partial deletion and addition of chromosome 7 from the same embryo, highest level embryo from my fertility clinic?
Well, according to these studies, you're looking at somewhere between a 40 to 50% implantation rate if it's a low-level mosaic. So it's a pretty damn good chance.
At what point during an FET cycle should I start aspirin?
Before you start your stim, that's when we started.
Also, do you recommend home testing after a day 5 FET?
No. In fact, I would strongly caution you against it. The nail-biting 2-week wait, the TWW, is horrible, and I get it. And I really do, and I respect all of you for struggling through that. But sitting on Google and checking every symptom and that anxiety and all of that stuff just drives everybody crazy. And then you're buying the early kit, which we tested. I mean, it didn't even work when we tested it, remember? Testing all of these things, none of these work that well. Like if you read the earliest test kit, which says it can pick it up at 8 days, it only detects it in 67% of cases. So then you're even more nervous, and all that anxiety actually reduces your chances of success. So do not mess with that, no matter how hard it is. Stay off of Google. For God's sake, stay off of Facebook, because there's all the crazy anti-vaxxers out there. Just do what you need to do to stay sane and wait for 10 days to 2 weeks and then get tested.
Does celiac disease have any negative effect on fertility?
We don't know. We're not sure. There are some studies that say it does, and most studies say it doesn't.
Is it safe to use Ativan or any meds for anxiety on a rare but as needed basis while preparing for after doing an FET?
Yeah, that's fine.
I'm going through these really quick today. I'm expecting something.
Hey man, we might be on time for once.
Yeah.
That would be great. Yeah, Ativan's safe. There's no risk. I mean, if you're doing it every day, that's not a good idea. But if you're doing it once in a while, you're fine.
If a person has multiple failed FETs on untested embryos, 28 and 29 when they were made, what testing could be done?
28, 29 or 20 and 29?
28 and 29.
Oh, okay. Yeah.
What testing could be done since you aren't a fan of the ERA? Oh, someone knows. I like that.
It's not that I'm not a fan of the ERA. It's that the ERA has been proven in multiple different trials to be useless. So I'm a believer in science. I'm not a fan or not a fan of anything. So what tests can be done? Fertility testing to look for infection in your uterus. Your genetics, your partner's genetics would be reasonable to look at. Hysterosonography to look at the shape of your uterus, or a hysteroscopy to look at the shape of your uterus. Surgery to look for endometriosis. There's all sorts of things. Detailed hormone look, your thyroid, your vitamin levels, vitamin D, iron. I could go on and on and on, but there's a bunch of different tests that can be done, which will improve your chances and dot every I and cross every T. Again, as always, if your body mass index is either too low or too high, that is critical to deal with as well. So there are a lot of factors that go into it. It's not just having a normal embryo. It doesn't guarantee you anything, actually. So if you're not perfect and the embryo is not perfect, it's not going to be perfect. That was probably the dumbest thing I've ever said.
It's okay. It's okay. I'll let you hang on it for a little bit. Is it normal to have a luteal phase cramping for the entire 2 weeks after IUI? Or would this be indicative of endometriosis or another condition? I had 4 IUIs with 2 weeks of pain every time.
That's unusual for sure. I would want to have a detailed look at you and figure out why. It could be endometriosis. It could be adhesions inside. If they're making you make multiple eggs and you're releasing them into the wrong place, that can be really bad. So yeah, all of those are possibilities.
I have heard that sometimes embryos can fail to implant due to the body rejecting it. I also heard different blood types can impact this. Is this true?
No.
Can any testing or meds be done to prevent this?
So the blood types have nothing to do with implantation potential or failure. So that's totally not true, and that's being looked at. There's all sorts of different tests that can be done, basically the same ones I just mentioned. So the fertility testing, hormone testing, vitamin testing, genetics, thrombophilia screen, infections in the uterus like ureaplasma, mycoplasma, or even at the cervix, adjusting your bacterial flora, the normal bacteria that are in the vagina or the uterus, making sure your diet is healthy, your weight is good. All of those things are important factors to improving your implantation potential.
Benadryl, Claritin, and Pepsid was recommended to me as a
Yeah.
antihistamine protocol to assist with potential hyperactive immune reactions.
Yep.
Does this make sense? Chronic asthma and allergies, 38 years old, FET.
Yeah, so we don't know. I've looked it up. There is no data on it at all. So it's hocus pocus right now. Is it going to be harmful? We don't know. Is it going to be helpful? We don't know. I don't use it. I did it once for a patient that said she was insistent she wanted to try it, and it did nothing. To the best of my knowledge, it's used rarely. Most people are not doing that because there is no scientific evidence to support it.
Okay. Thank you so much. I will discuss those 3 options with my doc. I have had a C-section for my first fresh transfer. So thank you.
Yeah, that might be the one that had the fluid in the uterus. Yeah.
Low AMH, bad responder to stim. 1 positive resulted in miscarriage at 9 weeks. What's best as next steps? All genetic gain normal, high FSH and bad responder is diagnostic. Positive from canceled IVF turned IUI.
Well, your options are keep going, doing your IUI, switch to IVF with pre-implantation genetic testing. Even if you're only making 1 or 2 eggs, it can still be done. I just did IVF for a very special patient of ours. And she only made 2 eggs, and we made 1 embryo, and it was euploid. So she's now got 1 euploid embryo. She's got very weak ovaries, but at least we got 1 normal embryo. So all you need is a couple of those normal embryos, and you have a reasonable chance. Your alternative would be to consider doing IVF with donor eggs, and that's obviously going to give you a much higher yield and a much better chance. But it's basically try with the IUI, try with the IVF, or move to donor. Those are your options.
Is there an American version of Fertility testing that you know of for faster results?
Oh, no, and I don't know of anybody that's faster anyways. The closest thing is Emma and Alice from iGenomics, but that requires a biopsy of the uterus, and they don't do the same things that Fertility does. So I would stick with Fertility, and Fertility is quick. I mean, you get your period, you get your sample, you send it off, they give you a result in about 2 weeks. They're pretty reasonable. They're expensive now, which I'm trying to get the guy to improve.
Is it possible to get more than 1 egg in a natural cycle? Is it true that those eggs are of better quality than of a medicated stem cycle? Do they have a better chance of having live birth?
So scientifically speaking, they've actually studied that, and there is no difference in embryo quality, genetics, outcomes, anything between a natural cycle, IVF cycle, and a stimulated cycle. Having said that, that's the science. In my personal practice, I feel that the embryos we get from natural cycles are actually better. And we have had patients that have responded very poorly to, stimulation, and then we do natural cycle IVF, and they do great. So I'm a believer, but scientifically speaking, it's actually not supported by the data. So I don't know if it's an issue of we need more studies or my experience is just different. It's hard to know.
I had 1 IVF and only 1 egg was retrieved. 1 egg was fertilized. Doctor advised if I want to get in, it has to be on day 3. When I asked the doctor how was the cell divided, and she said 9 cells. Doctor said it's good to do a transfer on day 3. Any comments?
Yeah, so I mean, if you're only getting 1 egg, your ovaries probably weaker, and so it's that age-old question of would the embryo do better in you than it would in the lab versus is this a normal embryo or an abnormal embryo? So your risk of the embryo being genetically abnormal is higher, and we've reviewed that on the show going back a couple of months ago, where we examined the fact that if your ovaries demonstrated diminished ovarian reserve, your chances of having genetically abnormal embryos was higher. So if you do a day 3 transfer, you are putting the embryo in the best environment possible for growth, which is your uterus, but you don't know if you're putting in a normal embryo or not. If you are waiting till day 5, obviously the lab is never as good as your uterus as far as a growth environment is concerned. But then you get the chance to find out if the embryo is normal or not. It's a real toss-up. As a general rule, if you can afford to do the IVF several times and bank a bunch of embryos and then send them for genetic testing, that's what I would recommend. If you cannot and you're only going to do it once or twice, I actually would advocate for doing that day 3 transfer because it doesn't make sense to wait.
I have stage 4 endo.
Oh,
Period was very painful before surgery, but after the 2 surgeries and 7 months of being on Lupron, the pain is a lot better now.
Okay.
Is it possible that my endo got better?
Not if you had stage 4. Stage 4 is basically everything stuck to everything. So it's unlikely your endo is better. It may be dormant, but there's still going to be adhesions in there. So the endo may be better, but there's still going to be scarring and damage from the endo. Sorry. I wish I had better news for you.
Follow-up from blocked tubes after DNC. Could an infection from retained products cause blocked tubes? I did not show any signs of infection.
Yes, but typically the infection from retained products would be anaerobic bacteria, aerobic and anaerobic, but it's not going to be chlamydia and gonorrhea, which are the ones that mainly climb up into your tubes and do the damage. So look, there are lots of women with retained products. Most of those women do not end up with blocked tubes. So it would be highly unlikely that that is the case.
2 failed IUIs attempting gonadotropin.
Yep.
Gonadotropin injection. Will this really increase your odds of pregnancy? I'm 37.
Yeah, for sure. So pills or natural will give you anywhere from like an 8 to 15% chance. Going up to the shots gives you 20 to 25% chance. So yeah, that's been well studied, well documented. The shots give you a better chance because you're probably going to make more eggs. So it's not an egg quality issue. It's just an egg number issue. And if you can make more, then you have a higher chance. Just keep in mind, it also has a much higher chance of multiples and a much higher chance of high order multiples, meaning triplets, quadruplets, and so on.
Is it possible for your lining to be thick enough to do an FET, but have your progesterone levels still be too low?
Yeah, absolutely. Yeah, I mean, you can have low progesterone levels and have a thick lining. Those two, if anything, go against each other. So a thick lining would probably suggest a lower estrogen or progesterone level. So you may need to increase your progesterone to get the lining to compact a little bit.
What are your views on intralipid infusion, also prednisone and naltrexone during STEM?
What was the other one?
Naltrexone.
Oh, there isn't a lot on naltrexone, although in PCOS it has been shown to be beneficial. I don't use it, but it has been shown to be beneficial. We don't use it during any of our stims. I haven't looked at it for a long time. Maybe that's something to take a peek at. Maybe make a note of that, and we'll do it for next show. We'll review the reviews of naltrexone in the next show. In terms of what was the other part of it? I got stuck on the naltrexone.
Prednisone.
Oh, prednisone and intralipids. We use intralipids and prednisone all the time. If you've failed previously, or you have some sort of immunological problem, it's a very reasonable start. Prednisone, intralipids, heparin, all of those can potentially be beneficial. Very, very controversial. If anything, the one that has the most evidence for actually being beneficial is the intralipids.
My husband had a varicocelectomy in January.
Varicocelectomy, yep.
Varicocelectomy. January numbers are all normal now, except DNA frag is 30%. Our doctor said to get another ultrasound to see if embolization is needed. Do you think this is necessary?
No, I would just do the things you can do to improve that. No smoking, no drinking, no drug use. If he's heavy, bring his weight down. Put him on tons and tons of fertility vitamins specifically for men to improve the DNA fragmentation. Make sure he ejaculates every 2 days. Make him sit on frozen peas for 20 minutes a day to keep the testicles cool, or even more per day if he can tolerate it. No hot tubs, no saunas, no jacuzzis. And then if you're trying with insemination or IVF, there's a good study that showed that if you ejaculate and then 3 hours later ejaculate again, the second sample has way less DNA fragmentation than the first sample does. So there's all sorts of things you can do without having to do an embolization.
Is there anything wrong with having short periods? Since age 12, mine have always been about 3 to 4 days. I also have PCOS.
As long as you're ovulating regularly, there's nothing wrong with having short periods. That's totally fine. If you're not ovulating regularly, the duration of your period is not the problem. The fact that you're not ovulating is a problem.
I'm poor responsive to stims since I had about 13 days gonal and orgalotron. Yeah, but much better on letrozole. I can have 4 eggs developed on letrozole, and I'm age 43.
That's okay. I mean, if you do better on letrozole, take letrozole. There's no magic to stims, guys. Like, some people will respond better to one, other people will respond better to the other. Take whatever works. That's fine. You can even mix letrozole with the shots to see if you can get even more, and that's commonly done. So that's perfectly fine. If you can get 4 eggs with letrozole, get your 4 eggs and then get them retrieved and turn them into embryos. Just remember, at 43, you need a lot of eggs in order to get just even one genetically normal embryo. So that's a bit of an uphill battle, but it's possible. And if you're doing fine on the letrozole, just do it a bunch of times on the letrozole.
What causes weak ovaries in younger patients? I just turned 34 and have an FSH and a low AFC and low AMH.
Usually autoimmune disease or genetic problems, exposures to chemicals, chemo, radiation. Those are the majority of it. So women, for example, with thyroid autoimmunity have a much higher tendency to have ovarian failure. There's a whole family of proteins, BMPs, DAX, that can cause it. You could be genetically abnormal. So whether it's FMR mutation or other mutations that can cause as well, or uromosaic, that's a possibility. Also, Turner's mosaics have weaker ovaries. The other potential is, as I said, that there's been some sort of exposure, whether it's infection or chemo or radiation. The last one is that there are women who have an excessive number of veins around their ovaries, and that vein probably causes overheating. And when the ovary overheats, your risk of having a major issue with ovarian dysfunction is much higher. So those patients should probably have those veins treated, but that's not an easy thing to do.
Receptiva DX results showed positive for CD138, positive for rare stromal plasma cells. What does this mean, and what are the implications?
Well, it means you could have chronic endometritis or irritation or inflammation in your lining. It has been associated with a decrease in implantation and ongoing pregnancy rates and a higher risk of miscarriage, most likely as well. The makers of Receptiva DX are probably going to argue that it suggests you have endometriosis. I think that's nonsense. So kind of up to you to decide what to take out of it. But if your CD138 is high, that's a marker for inflammation in the lining of your uterus. I just am reviewing a paper. Actually, I just finished reviewing a paper that was submitted to one of the journals I review for on specifically CD138. So that's what that's from.
I have had failed IVF procedure for 4 times, despite having a good egg quality and good quality embryo. My doc said I had
adenomyosis.
Yep. Advise. I'm 40 years.
Adenomyosis normally, unless extremely severe, should not be stopping you from success with 4 different IVF cycles. If you have genetically normal embryos, you're one of the patients that should reach out and DM me, like direct message me, and I will happily help you, or just reach out through info@drvictory.com. Set up an appointment. I will go through things with you. Usually we can figure out what's wrong and help you no matter where you're doing your treatment.
Hi, Dr. Victory. What can a patient expect in the first appointment with you? Due to time sensitivities, are you able to order all necessary testing then? Thanks.
Yeah, so during our first appointment, we go through a very detailed history. I make sure I learn everything about you and your partner. We go through what you've done, what needs to be done. We outline all of the testing that's available. We go through what you want to do and what you don't want to do. We obviously encourage you to do the ones we recommend. We get all of the tests lined up as quickly as possible, and then we do them. So it's pretty straightforward. I usually spend about 20, 30 minutes during the call or Zoom, or if you're here in person, and then we sort out what's wrong. A lot of what we're doing these days is second opinions, because people are coming to us from all over the world. So we do a lot of that, filling in the blanks where other people are just practicing cookie cutter medicine, and we're really trying to explain to them what they need to do to succeed. 9 o'clock.
9 o'clock.
Yeah.
All right.
We need some kind of alarm.
The adenomyosis?
Yeah.
Nigeria.
Oh, Nigeria. Hello.
And she will surely DM you.
Yeah, DM me and I'll happily help you. No problem. And I'm sorry you're going through that.
Okay.
I've had a bunch of patients from Nigeria.
It's global kind of
I did a Zoom with a lawyer from Nigeria. I don't know what happened after that, though. Yeah.
Sorry if you already answered this. The option of transferring 2 embryos was presented to me, but I already had a T-shaped uterus, and fear my uterus doesn't even have room to grow 1 baby, let alone 2.
Yeah.
Would you suggest transferring 1 to be safe, or 2 to increase my chances of successful transfer?
Always 1. And if you have a T-shaped uterus, it's easy to fix. So get them to fix it first. You just go in and cut the sides, and then it becomes a normal shaped uterus. So get that done. Tarek goes, I can do that. That's not that easy. But I can teach pretty much anybody. But I won't let Tarek do your surgery. Don't worry.
Follow-up question for Endo. You want to end it on this one?
Yeah, I'm game, man. You fire away.
Okay. Follow-up question on Endo.
We got pecan pie to finish.
I saw
That's an important thing for us. We do like to eat, Tarek and I. Yeah. Yeah.
What are the negative impacts of endo on implantation and live birth? I have been told by my doctor that endo is outside of the uterus, so it doesn't have any impact on implantation. I even know that.
Tarek would like to answer that question because he's sitting here going, that's crazy. Even I know the answer to that one. So listen, endo most definitely has a negative impact. If your physician is telling you that because it's outside the uterus, it doesn't, they don't know what the hell they're talking about. So endo increases the inflammation in your body and overactivates and overstimulates your immune system. An overactive immune system has impacts on egg quality, on embryo formation, blastocyst development, implantation, ongoing pregnancy rate, all of that stuff. So there is absolutely a gajillion studies that show that endometriosis decreases your success rates. So your doctor is either not aware, or as Tarek just gestured, or your doctor is trying to get your money and doesn't care about the fact that you've got endo. Now, you can treat endo medically. It doesn't have to be treated surgically, but does it need to be treated? Absolutely, you need to find some kind of treatment for endo before you get pregnant with fertility treatment, because it's going to decrease your chances. And if you're spending money for what you're doing, you want the best chance every time. So simply saying it's not important is a very flat out large mistake. I don't want to say lie because I don't know the motivations of the person or the person we're speaking about, but it's definitely a mistake. That's not true. Categorically not true. Easy to prove. There's a gajillion studies on how endo decreases success rate.
A lot of people are laughing on our commentary on
That was so funny. Tarek in the background is going like this for the doctor. Yeah, listen, one thing I experience more and more as we become the go-to for people that have failed in other places and actually want good treatment coming from us, is the fact that a lot of places just don't know what the hell they're doing. Like legitimately, they have no idea what they're saying or telling people. I'm getting some of our international clients telling us that their center is willing to follow our protocol because they don't understand what we're doing. I mean, how can you not understand? Everything we do is based on the scientific stuff we present on this show. So if they're not reading every day, and yes, granted, I spend every bloody day reading. If they're not reading every day, they're not learning. How are you going to keep up with the best of the best? Like, how are you going to help people if you're not looking for answers to things 24/7? I'm constantly looking for answers to things. So yeah, you got to work with centers where they actually know their stuff. A patient recently reached out to me and said, what kind of questions should you ask to figure out if a center is good or not? And, I had to really sit down and think about it, but I came up with like this exhaustive 10-point list. And I think those are important things to ask. So, just jumping into a center is not enough. You've got to go somewhere where they actually know what they're talking about. I'll give you the best example I can. We jumped on to DuoStem 2.5 years ago, probably, right? 2 years ago. We started doing DuoStem because the studies started coming out and they were very favorable and we were doing it. There are places that still don't even know what DuoStem is. You can't be, keeping up with knowledge and claim that you're an REI and that you're a good fertility specialist if you don't know what one of the most important, developments in helping women with, diminished ovarian reserve is. Like, it's literally one of the best things you can offer patients. And if you package it correctly price-wise, you can provide them with a huge amount of help. We reduce our DuoStem price by almost 30% for the second cycle, whereas I've got places in Toronto that are charging even more for a back-to-back cycle than they are for 2 separate cycles. Like, that's evil. It's immoral. We're here to help you guys. So, make sure you find a doctor or a clinic, or even if it's just the amazing nurses, like, find somewhere where they really want to help you, not because you're a dollar sign, but because they practice medicine. Medicine is about the art of healing. It's about taking care of people. That's why I do what I do. Like, honestly, I don't care about the money. It makes no difference to me whatsoever. So find people that care about you, care about being good doctors, care about answering to a higher power than their wallet. I think that's the most important thing you can do. End it on that. That's a good. Tarek's going, end it. Okay, guys. So have a good night. And we will see you again next week. I guess we'll be talking about naltrexone. Naltrexone? All right, we'll talk about naltrexone. I will find out everything there is to know about naltrexone. I do know it's helpful for PCOS. I don't know if it's been shown to be helpful for FETs. We have our patients on so many supplements for FET. I think if I throw in naltrexone, they'll probably revolt, but we'll see. You guys have a great night. Please, for the love of God, do not become Facebook MDs. Do not try and read stuff about anti-vaccination. It is all 100% idiotic drivel. So don't read that stuff. Don't watch that stuff. Don't pay attention to that stuff. The people that are reading that do not know what they are talking about. The people that are not reading it, the people that are writing that stuff do not know what they're talking about. They literally have no clue what they are saying. The best example I can give you, and I'll just leave you with this really quickly, is one of my colleagues said to me that they were, that the vaccines were killing women's ovaries. And this is why I had that post on Instagram about the rats, okay? So I won't go into too much detail other than to say that the reason they claimed it was killing women's ovaries was from a study done by Pfizer where they gave 1,333 times the human dose to a rat and then killed the rat literally days later to look at how much of the vaccine got into the different organs and found 0.1% of the fat got into the ovary. And ovaries naturally have fat in them anyways. So they then said it's rendering women, so this was done in a rat, women infertile. They didn't even give the chance to the rat to procreate. They killed the bloody thing before it had a chance. It's insane. Like, it's so stupid, it's ridiculous. So I went back to my colleague who told me that this was the thing. And I said to him, this is the data you're claiming supports you being an anti-vaxxer. And his response was, that doesn't matter. So this is who we're dealing with. They don't care about the truth. They only can see tunnel vision what they believe. Look, if you can prove to me that the vaccine is dangerous, I will believe you. I don't have tunnel vision. I have science vision. So show me facts, I will believe them. But telling me that the VAERS system where they're reporting by cell phone that something has happened is valid data, or telling me that, you know, a rat is equivalent to a human being and that the fat accumulating in the ovary means that women are going to be infertile is idiotic. Like, there's no other way to put that. It's actually idiotic. It's ridiculous. So please, please, please go get vaccinated. Have a good night, guys. Bye.